So weaning is a form of art, and it is the science of liberation too. In intensive care practice, we take care of A, B, C, D, E, F bundle. Pain management is definitely there. Spontaneous awakening trial and spontaneous breathing trials are there, which we'll discuss further. Choice of analgesia, sedation, delirium management, early mobilization, of course, family engagement and empowerment, everything taken together will produce a good package of intensive care management, especially when mechanical ventilation is involved. As I said before, we need to focus on the patient and his problems rather than focusing much on the sophistications of mechanical ventilation. The mechanical ventilation, sophistication, modes, alarms, everything is for your help in assisting the patient recovering from his pathology. How do you assess the readiness to wean? First, the reversal of the indication for ventilatory support. There should be good enough reasons to believe so. The gas exchange should be adequate with the indicators like good PaO2, reduction in FiO2 or oxygen requirement, reduction in PEEP requirement, the pH coming close to the physiological one, VD by VT less than 60%, patient not hyperventilating, etc. Definitely patient should be hemodynamically stable also. There should be minimal cardiovascular support, no evidence of cardiac ischemia ongoing, no unstable arrhythmias. And patient, when he starts to initiate breath, you should be preparing yourself to assess the readiness to wean. It is said that more than 40% of the time on mechanical ventilation is spent on weaning the patient from mechanical ventilation. What are the weaning parameters? These are used to predict the weaning readiness. Okay, you assess for three major categories. You assess the ventilatory drive, ventilatory muscle capabilities, ventilatory performance. Ventilatory drive is assessed by the value called P01. Don't get scared. It is the value given in modern mechanical ventilators. Should be more than -4 centimeters of water. It is the airway occlusion pressure during the first 0.1 second after beginning an inspiratory effort against an occluded airway. So that is the checking of ventilatory drive. Then something about ventilatory muscle capabilities. When the vital capacity is more than 10 mL per kg, minimum inspiratory pressure, MIP or NIF, less than -30 centimeters of water. Ventilatory performance indicators like minute ventilation less than 10 liters per minute, maximum voluntary ventilation more than 3 times the minute ventilation, rapid shallow breathing index or RISB less than 105, and respiratory rate less than 30 per minute. How do you do spontaneous awakening trial? It starts with a safety screen. You have to roll out the contraindications like seizures, alcohol withdrawal, raised ICP, moribund status, waiting for withdrawal of life support. Cardiovascular system, you check for shock, high requirement of pressors, myocardial ischemia within the last 24 hours, or if the patient is on post-cardiac arrest hypothermia protocol, you can't go for spontaneous awakening trial. With regard to respiratory system, if patient is ventilator dependent, you cannot opt for spontaneous awakening trial. So is the case with ongoing neuromuscular blockers used. There should be a checklist. Neurologically, you check whether the patient opens his eyes, looks at the caregiver, squeezes his hands, or put out the tongue. 3 out of 4 would be very much desirable. And then you check the objective indicators like saturation more than 88% on an FiO2, less than 50%, and a PEEP less than 8 centimeters of water. Spontaneous effort in the last 5 minutes period, no evidence of myocardial ischemia in the previous 24 hours, no significant use of vasopressors, no agitation, no evidence of raised ICP. So there should be a protocol. Most of the ICUs will have a protocol to perform this. The inclusion criteria being presence of spontaneous breathing, no planned procedures, no ventilator dependence, and the pain scores acceptable. If everything is yes, then check for the screening criteria. Saturation more than 88% on FiO2 less than 50%, PEEP requirement less than 8 centimeters of water. Patient should be hemodynamically stable and rhythm should be stable. If yes, conduct 1 minute screening for spontaneous breathing trial. Check whether RSBI remains less than 105 and respiratory rate is less than 35. If it clears that 1 minute check, you can proceed with the spontaneous breathing trial for a minimum period of 30 minutes to a maximum period of 120 minutes or 2 hours. If it is a short period of ventilation, 30 minutes of SBT should suffice. If it is a longer period, you need a longer trial period to see whether even off the ventilator support, patient will maintain the oxygenation, ventilation, and airway protection. Okay, so if that is cleared, that means RSBI does not exceed 105 for 5 minutes. Saturation is not dropping below 90% for more than 2 minutes. No arrhythmia. Heart rate stays less than 140% or 20% increase in baseline. You can declare as SBT passed. If SBT is passed, then you can check for the secretions, positive airway leak test. The cuff leak test you can perform, which is not 100% conclusive though. Then record the results and multidisciplinary team decision. We can proceed with the extubation if the spontaneous breathing trial is successful. How do you do spontaneous breathing trial? It is a mechanism used to assess the patient's ability to breathe with minimal or no ventilatory support. Original option was CP's trial, where humidified oxygen was connected directly to ET tube along the GPs. Other options are when the patient is still connected to the ventilator through the circuit. You can do a CPAP trial with the CPAP level equal to the current PEEP level, or you can provide a low level of pressure support, or you can go for automatic tube compensation. Okay, the advantage is since the patient is attached to the ventilator, you can maintain the precise FiO2. And in case the patient fails the trial, they can be quickly placed back on the full ventilatory support, or you can set backup mode settings. Along with the weaning, you need to be vigilant about what sedation analgesia is going on. You should be familiar with the common drugs used for sedation analgesia in the ICU. You should be familiar with the elimination half-life, whether it is affected by renal or liver dysfunction. And is there any possibility of active metabolites accumulating? That also you need to consider before deciding finally on extubation. Pharmacological weaning plan, it's important that sedation scoring and ventilator mechanics both are taken into account. And there should be a caution about polypharmacy and SOS or as needed dosing, which might interfere with your plan for spontaneous awakening trial or SBT. Patients awaiting an spontaneous awakening trial, failing an SAT, you can restart sedatives at the half the previous dose and then titrate for comfort depending on which sedation score you are using in your ICU.